certified dermatologist and pediatric dermatologist. She was born in New Orleans, raised in Scottsdale. I went to the University of Colorado, got her medical degree at Tulane University, and then finished her dermatology training at Mayo Clinic, as well as pediatric dermatology in Phoenix Children's Hospital in Arizona. She has been in Colorado up until 2020, and then she moved to Boise, Idaho to become the first and only pediatric dermatologist in the state of Idaho. I absolutely adore Dr. Swanson. Not only does she have a love for life, but she also has a passion for pediatric dermatology and being able to make a difference in her patients' lives. And I really look forward to hearing what she has to tell us. So,
thank you so much. Thank you. Perfect. Thank you. Hello, everybody. I'm going to need to bring this way down. I'm a shorty. Hello, everybody. So nice to meet you. I'm so excited to be here. I have so much to tell you. I don't know about you guys. I feel smarter after that last lecture. Don't you all feel smarter? I definitely picked up a lot, and I've been doing dermatology for 15 years. And so now we're going to segue into stuff that will also make you feel smarter, but stuff that you can have a whole lot of fun with, because Peds Derm is the best, you guys. I love what I do. It's so fantastic. You get to play with kids all day. You get to watch cartoons in your waiting rooms. It's all super, super, super fantastic. Thrilled to be here. My email address is included at the beginning and at the end. Please feel free to reach out to me. There are just over 400 pediatric dermatologists in the entire country. There are still 7 states without one, and so I think it's the duty of every Peds Derm to be a phone-a-friend to any who you want to. And so please feel free to reach out to me. Happy to help. These are my disclosures. I wanted to start out with a story about my dad. This is my dad, and my dad is a urologist, kind of sort of recently retired. He's one of those where he retired and it didn't quite stick, and then he got back to it. And my very first job when I was 14, 15 years old was working for my dad. And this was before PubMed, this was before UpToDate, this was before the internet. And so he had me catalog his journal articles for him. And he paid me like 10 cents an article. And so he'd find an article he found interesting, he'd tear it out, he'd write keywords on it. And then it was my job to enter in keywords, author, title, that sort of thing. So he could find them when he was preparing for a talk, etc. And I'll remind you guys that these were urology articles, a lot of which that had urology pictures in it. So I'm 14, 15-year-old me looking through this stuff like, what the heck does my dad do? And I went to him one day and I said, Dad, urology is gross. Any urologists here in the room? Any? No, they're all busy. They're cystoscopying and they're doing all that stuff. But I said, urology is really, really gross. Why on earth did you choose it? And I grew up with my dad telling me, Lisa, there are 2 kinds of doctors, urologists and those who wish they were urologists. And I'm like, Dad, I don't think that's true. And I feel like I've seen enough of the evidence now to know that that's not the case. Why on earth did you choose urology? And he said, well, Lise, it's because I can fix it. And that really resonated with me, and that's part of the reason I wanted to be a doctor, and part of the reason I chose dermatology, and part of the reason it's so exciting to be in derm and Peds Derm right now. It's just such a magical time. We have more of an ability to fix our patients than ever before, and I'm going to show you several stories and several pictures that show that. Even if you don't see a lot of kids in your practice, I think you're going to get a lot from this talk, whether it pertains to your practice seeing adults, because very few of the things I'm going to talk about today are exclusive to kids, or for yourself, or for your children, or for your grandchildren, or for the neighbor that texts you a picture of whatever their kid has at 10 o'clock at night. And so I think you will learn a lot from this talk that you'll be able to put to good use. This is our table of contents, so we're going to do some rapid fire Peds Derm, then updates. Oh, actually, it'll be okay, but this is my old presentation. If a switch is doable, that would be great, but if not, I'm cool, because we're going to talk about rapid fire Peds Derms and then atopic dermatitis, and then updates in autoimmune inflammatory skin diseases in kids. So I always like to open with a quote, and this one's one of my favorites. Obstacles do not block the path. Obstacles are the path. What famous philosopher said those words? No, It was Bandit, the dad on Bluey. Yeah, yeah. I'm a huge Bluey fan, big time Bluey fan. I don't have children of my own. I watch Bluey all day, every day. I love it. Can't get enough of it. Same with my doggie. This is my doggie Maggie, eagerly watching the Bluey episode that we have on. My other doggie Mosby couldn't care less, but Maggie, she loves it. And so you don't have to have kids to watch Bluey. It's wonderful and cute and funny. It's about an Australian dog family in Australia, and it's so wonderful. Okay, rapid fire peds derm. We'll start with hemangiomas. This is one topic that is exclusively for kids, and this is me. So hemangiomas and I go way back. I had 3 hemangiomas, the 2 you can see here and then one on my head. And my mom tells me that I was destined to be a pediatric dermatologist because me and hemangiomas go way back. But I love hemangiomas. I love seeing hemangiomas. I love treating hemangiomas. I love everything about it. This is the hemangioma life cycle. I drew this myself, you guys. I'm very proud. Thank you. Thank you. Yes. Because you have no idea how hard it is to draw a straight line in PowerPoint. It's actually very difficult, and I had to do it 3 times. And so a hemangioma is typically not there at birth or barely there at birth, and then it appears and starts to grow, and it can grow until the child is 9 to 12 months old. Then it enters a plateau phase where it stays the same for a while, and then it starts going away. We call it the involution phase. And involution is complete by the age of 10. This is important because it gives parents a good idea of what they can expect from the natural evolution of a hemangioma. It also helps you discern if something maybe isn't a hemangioma. So if something is present at birth fully formed, that's not a hemangioma. And so the life cycle is important as you're taking the history of the spot. Propranolol is still awesome. How many folks in this room prescribe propranolol for whatever purpose? I bet a lot of people do. Yeah, it's great, right? Everybody's doing it. Like you could do it for stage fright. I'm on propranolol right now, vitamin P. Just kidding, no, I'm not. Propranolol is safe and wonderful and effective and awesome, and it really, really works well to treat hemangiomas. So if a hemangioma needs it, use it, don't be afraid. We typically treat for the first 9 to 12 months of life. After that, it still works, but not as well. And we know we get the best benefit. I'm just gonna move this a little bit over here. We know we get the best benefit if it's started the first 10 weeks of life. So that's really the sweet spot there. And here are some pictures of a kiddo showing rapid improvement with their propranolol and slow improvement with their hemangioma over time, and they're a happy kid. So when I'm treating with propranolol, I see the patients every month at first to assess progress, take pictures, make sure everything's okay, and then we space out the visits to every 2 months after that. I take pictures at each appointment to monitor progress, and we treat until the child is 9 to 12 months old. Then we taper off, doing just a 2-week taper, and let the rest of the hemangioma involute on its own. With propranolol, you might not get the hemangioma completely gone, but you accelerate that graph that I showed you. Instead of taking a year to reach to peak and then starting plateau and then eventually involution, you're resetting that clock. So you're going to get the hemangioma gone sooner, even with Mother Nature's work, after you're done with the treatment. This is what I counsel families about when starting propranolol. The number one thing is always give with food. The medicine can cause hypoglycemia, so if you're always giving it with food, that will not happen. 15 years of practice prescribing propranolol every day, I haven't had a single baby have hypoglycemia on propranolol, and I think it's because I tell them, give with food. In fact, I tell the parents, if you forget everything else I said today, just remember to give with food and you'll be all right. Slight decrease in heart rate and blood pressure hasn't been found to be clinically significant, and so we don't even check anymore. We used to. We used to bring the babies in every month for heart rate, blood pressure check. We learned that that's not necessary. Increased tendency to wheeze with respiratory infections, and so if a child gets sick, we have them stop the medicine until the child is well. And sleep disturbances, you look on the internet and maybe you see some sleep disturbances, but 2 well-done studies have said no, but it's still a little bit controversial. I remember when I was a fellow in peds derm and propranolol was still a new thing, and anytime I ran into a pediatric cardiologist, I would ask them about it. I'd say, hey, peds derms, we're prescribing propranolol now. Are we off our rocker? Are we outside our scope? And one peds derm said it the best way I can think of. He said, in the doses you guys are prescribing for babies, I would prescribe propranolol over the phone for a baby I had never met, and I would never follow up. It's just that safe in these doses. And so we can feel quite comfortable with this. The generic propranolol tastes minty. Most babies do fine with it. Some babies really hate it. There is a brand name version, and the only thing that sets it apart is its name because it's still propranolol. So I'll use its brand name once. It's Hemangiol, and it's formulated to taste better for babies, and babies just love this stuff. Like, you give them a little Hemangiol, and they're like, they grab the syringe. They love it. They're like in old school, like, fill it up again, you know? Like, it's so good when it hits your lips. Like, they love it, love it, love it. We have long-term studies looking at babies who grow up after having been on propranolol, and we've seen no negative consequences. In fact, the second grader study at age 7, the kids were doing better than their peers, the kids who were exposed to propranolol. Which hemangiomas need propranolol? Well, big ones, ulcerating ones, hemangiomas in functional locations that are going to interfere with walking and crawling, special site hemangiomas like the eyelid, nose, and lip, eyelid hemangiomas. If there's an eyelid hemangioma on the upper eyelid and it causes the eyelid to droop and occlude the pupil by half for 3 weeks, that baby will have permanent vision loss in their eye. And the reason for that is the brain no longer thinks there's an eye there, and they turn it off. And so we need to intervene quickly for these special site hemangiomas. Dome-shaped hemangiomas, the big Goombas, because even when they involute, they leave behind residual fibrofatty tissue that sticks around forever. And it's not dangerous, but a lot of kids don't like having that, and eventually they'll have it cut out later. We can prevent that from being necessary by treating the hemangiomas. I'm happy to coach you. Reach out anytime. You've got a friend in me. If you see babies with hemangiomas and you're curious to start treatment, like, reach out. I'll guide you through the dosing. I'll recheck your math. I'll help you with everything. Once you've done it a couple times, you'll be sold. When could you use topical timolol for hemangiomas? Well, so there are 3 types of hemangioma: superficial, deep, and combined. Topical timolol just works for the superficial strawberry hemangiomas. And you never want to put it on an ulcerating hemangioma because you can get unpredictable systemic absorption through the ulceration. We use the 0.5%. My preference is the gel-forming solution, but you can also just use the 0.5% eye drops. These are cheap and widely available. They're meant for eye drops. They're used for glaucoma, but we can multi-purpose them and have them used topically on a hemangioma. Think about topical timolol for pyogenic granulomas in kids. I totally agree with Dr. Margoob. You see an adult with a PG, you're going to shave that off. But in kids, pyogenic granulomas are so common that we can typically tell clinically what they are, and we can treat them with topical timolol. And it works great, and it doesn't hurt. So it's just 1 drop applied to your fingertip and applied to the PG twice a day. Takes about 2 to 3 months for complete resolution in most cases, but you're going to see improvement at a month. So I schedule follow-up for a month, and I'll show you pictures. So it's especially great near the eye in a little kid because who cares if it drips in the eye? It's an eye drop. So this was a little kiddo at baseline and then 1 month into treatment. Another kiddo, baseline, 1 month into treatment. Still some work to do for final resolution, but we're on the right path. Another kiddo, baseline, 1 month into treatment, and you save them from having a painful procedure in the office to shave it off. And again, great near the eye. So think about that for pyogenic granulomas next time one of those walks into your exam room. Next, on to warts. And this is really applicable to anybody and everybody because who doesn't see warts in their practice? So I'm about to change your guys' life. Are you ready for that change? You've already heard about Bluey, that's one big change, and then now you're gonna hear about warts. So there's this product that's made by a pharmacy in Iowa. They're called Nucara. I have no affiliation with them. They make the most phenomenal wart medicine. It contains salicylic acid and 5-FU in a proprietary medium. And so I think there's something special about that vehicle that allows slow dissipation of the active ingredients into the warts. You apply it at bedtime under sticky tape that comes with it. Do it every night until the warts are gone. Typically works 98% of the time, you guys. Doesn't hurt. Works fast. 3 to 4 weeks, you've got your warts gone. It's magic. I'll show you pictures. The pharmacy that makes it doesn't deal with insurance. It costs $99. It's worth every penny. Other compounding pharmacies will try to recreate the magic that is this product, and I'll say its brand name once because again, it's just 5-FU plus sal acid, but the brand name is what sets it apart. It's called Wart Peel, and so if you Google Wart Peel New Care, you'll find it, and you can prescribe it electronically or send in a paper prescription or call it in, whatever you like. But other compounding pharmacies have tried to recreate the magic that is Wart Peel. They can't. It doesn't work as well. They typically charge less for it, but it doesn't work as well. And so I strongly recommend the stuff from Iowa. This is before and after picture, June 10th to June 26th. Remarkable improvement. Another patient a bit older from October 14th to December 16th. Around the nail, it works super fantastic. You'll get some temporary onycholysis, but then it goes back to normal very quickly. This was a patient that I saw that had been treated with a wannabe Wart Peel product from a different compounding pharmacy. And so January 27th, we started the real thing from Iowa, and you can see already January 30th looking so much better. February 14th, it's basically gone. And this is how happy that kiddo was that his wart was finally gone after dealing with it for so long. A couple things about it. You don't have to treat each and every wart. The immune system will be triggered by the 5-FU. So say you see a kiddo that has warts on their hands and warts on their face, treat the ones on the hands. The one on the face will go away. Or if you have a kiddo that has 30 warts, it'll be a pain to put it on all those warts. You don't have to. Pick the 5 or 6 you hate the most, treat those, and let the immune system get to the rest of them. If a patient comes in and says it didn't work, I ask them, what happened? Because often what happens is they thought the wart was gone, and so they stopped and it came back, or it started to cause some irritation, and so they stopped using it. My theory behind this, there's an ingredient in Wart Peel that works destructively, the sal acid, and an ingredient that works to trigger immune system, the 5-FU. I think sometimes when you use it every night, which are the standard instructions, you get destruction happening very quickly, and it doesn't have time to trigger the immune system. So you think it's gone, but then it comes back, or it causes too much irritation because it's destroying too much. And so what I do in these situations is I recommend the slow simmer, where you use it Monday, Wednesday, Friday at bedtime instead of every night. And then it works like a charm. Can you use it on the face? Yes, but with more cautious instructions. So a teeny dab on a Q-tip, just Monday, Wednesday, Friday at bedtime, no sticky tape. And again, you don't have to treat all the warts. So you could treat 3 on a person's face that aren't in main line of sight and help trigger the immune system to take care of the rest. Hand, foot, and mouth disease has become a much bigger deal in recent years because of the emergence of Coxsackie A6. Coxsackie A6 is now the leading cause of hand, foot, and mouth, and it changed the way it presents. It now can happen in adults, you guys. There was a pitcher for the Mets that had to go on injured reserve because he got hand, foot, and mouth. It commonly causes onychomatosis, which is a shedding of the toenails. I'll show you pictures. It commonly causes diaper area involvement, and it commonly causes something called eczema coxsackium, which I'll show you pictures of as well. So these are classic pictures of hand, foot, and mouth. This is the diaper area involvement, and that is the foot of a 55-year-old man. So older people can get hand, foot, and mouth. This is onychomatosis. And onychomatosis is where your nail is growing along just fine, and then you get hand, foot, and mouth, and it temporarily stops growing, and then you get well, and it starts growing again, but it creates this kind of heaped up backup, and the old nail has to fall off, and then the new nail grows in behind it. It's harmless, it self-resolves, but I always know I'm seeing it if my chief complaint on my appointment schedule says nails falling off. I always know they probably had a hand, foot, and mouth about 8 weeks ago. Eczema coxsackium is when a kiddo with eczema gets Coxsackie, and the two merge to form this super rash called eczema coxsackium all over arms, legs, and face. I'll show you several pictures. Some people call this atypical hand, foot, and mouth. I like eczema coxsackium because I think it more accurately explains what's happening. Here are several pictures of eczema coxsackium. I think it is the most commonly texted photo to me. Sometimes, me and my boyfriend Larry will be watching TV, and he'll be up in the kitchen, and I'll hear my phone ding or something. I was like, oh, can you grab my phone? And he looks at it and he's like, oh God, somebody sent you a picture of something. 9 times out of 10, that's eczema coxsackium. More pictures of eczema coxsackium. In patients with skin of color, it can be more papular, but still eczema coxsackium. An asymmetrical facial rash on the face of a child is tinea until proven otherwise. An asymmetrical pink scaly rash on the face of a child is tinea until proven otherwise. And it can be mild, like the picture on the right, but it is tinea and it will blossom over time. This is what happens if you use varying degrees of potent topical steroids on tinea. It will progressively get worse and worse and worse and cause a fungal folliculitis. This is tinea capitis. The combination of scale and alopecia is tinea capitis until proven otherwise. Psoriasis doesn't cause hair loss. Sebderm doesn't cause hair loss. Eczema doesn't typically cause hair loss unless you're scratching really hard. So the combination of scale and alopecia is tinea until proven otherwise. If you see a kiddo with tinea on the hand, ask about pet rats, guinea pigs, hamsters, because they hold the little critter in their hand, and they might kissy face with the little critter, and then they're just sprinkling, crop seeding, crop dusting fungus all over the child's hand. And so that's the most common thing there. Resistant tinea is a thing, and it's now everywhere. So we are seeing lack of efficacy with terbinafine. We are having to use higher doses of terbinafine. We are having to use itraconazole. It is crazy. And so it has become increasingly important to do a fungal culture with speciation and sensitivities anytime you see fungus. And it's important to do it before you've initiated treatment, because after, it's not as reliable. There are only a few labs that will do the susceptibility testing on fungus. Our local lab in Boise will send it out to one of these three. They use the San Antonio one. So you don't personally have to ship it somewhere, but work with a lab that will. And my last high yield tip, always give teenage boys a snack after a biopsy or anything ouchy. Because these teenage boys, they will hit the ground like a sack of potatoes if you don't give them a snack. And it doesn't happen in the exam room. It happens in the waiting room or in the parking lot as they exit the premises, and boom, they hit the ground. And then a lot of times when they go down, they shake, you know, and so then everybody in the waiting room is like, oh my gosh, they're having a seizure. And there's just like pandemonium in your waiting room. And so give them a snack. Since instituting my mandatory snack policy for teenage boys, I haven't had a single boy pass out. So do that. Now, we'll move on to atopic dermatitis. And I put this in the form of questions that I get every single day as I treat kids with AD. Isn't there something natural that we can use to treat my child's eczema? Can I just say no? Can I just say no and move on? I so desperately wish I could. And sometimes I feel like Leslie Knope on Parks and Recreation when she's trying to convince the town of Pawnee that they don't need big buckets of sugary soda. And she says, all I have on my side is facts and science. And people hate facts and science. And a big part of it is the internet. And all the things that they have at their fingertips that they can get next day on Amazon Prime that are putting this bug in their ear about these natural therapies. Check out this one, for example, the mother of all creams, if you will. The name in and of itself, that's just fantastic. And then also you see that it describes itself as mildly earthy. What does that mean? Is there dirt in it? Like what on earth? And then you're like, okay, I'm gonna look at the reviews for some guidance here. So you see, this stuff was my savior. After I was diagnosed with a horrible case of perioral dermatitis, I used this cream twice a day for 6 weeks, in addition to doxycycline, prescribed by my dermatologist, and poof, magic, my rash was all better. How many of you think it was the mother of all creams? How many of you think it was the doxycycline? But a few natural therapies have been studied and can give us an olive branch to extend to parents and families who are interested in these things. Olive oil has been studied and was found to worsen eczema, shouldn't be used. Black tea compresses can be particularly helpful for facial eczema. Email me for a handout about how to do it if you're interested in recommending that to your patients. CBD, the jury is still out, but it might have some anti-itch properties. Coconut oil has good antibacterial properties, but probably doesn't help the eczema itself. If people love it, I think go for it. And then sunflower seed oil does appear to help, but it can be hard to find it can be difficult to find a good preparation of sunflower seed oil that doesn't contain a whole bunch of other junk in it, so that can be a hard thing. One thing I have borrowed from the integrative world is some of their language, because they use wonderful words like balancing, restoring, codifying, enriching. I didn't even know codify was a word until 2 years ago. But don't all these words make you feel really good, like warm and cozy? Whereas in traditional medicine, we talk about blocking, destroying, inhibiting, killing. And so I have started to pepper my descriptions of the mechanisms of action of my medications with this integrative language, and people love it. They're very receptive to it. They like it a lot. Next question, does food cause eczema? Can I just say no and move on? But very rarely can I just say no and move on in the exam room. We have so much evidence showing that food is rarely a culprit when it comes to atopic dermatitis. Like 98% of the time, it's not a factor. When do I think about it? Two situations. Within 30 minutes of eating said food, the rash gets worse, or in a little baby with bad eczema and bloody diarrhea, that can be a sign of dairy protein allergy. And so those are the two situations where I actually entertain it. But overall, we have so much evidence showing that it's rarely a food. And I tell patients in the office, I wish it was a food. Do you know how much easier my life would be if I could just tell people to avoid soy and then everything would be fine? You know, I wish it were a food. Unfortunately, it's not. But we have some wonderful ways to treat it and get it under control. We do not recommend elimination diets. They're rarely helpful. Kids need their nutrition, and we know that avoidance is linked to increased risk of allergy itself. We also have increasing evidence showing that it's actually the eczema that leads to the food allergy, that aerosolized food particles enter through the skin's broken barrier, trigger an abnormal immunologic response, which becomes allergy. And we have studies showing that food allergy is higher in patients with facial involvement of their eczema as opposed to patients who don't have facial involvement. There was even a small study out of Japan showing that treating the eczema reduced the risk for allergies in those kids. And so we really feel strongly you don't need to eliminate anything from your diet. I feel like my child will eventually outgrow this. And after all, it's just a rash. Why would I use dangerous medicines to treat a rash that will eventually go away? Well, it's because eczema is not just a rash. The impact of atopic dermatitis is huge, both on the patient and on their family. And I wanted to focus on a few, perfect, you did change it. Thank you so much. Okay, good. And so we'll get to that later. I'm going to focus on a few of those comorbidities in a little bit. So next question. I want my child's eczema to get better, but I will not use topical steroids because I heard about steroid withdrawal syndrome on TikTok. What are my options? So we have so many options nowadays. One thing that I love is called the Aaron regimen. Anybody here heard of the Aaron regimen? This is going to change your life if you treat kids with eczema. So it's a compounded mix that was created by a dermatologist in the UK decades ago named Dr. Aaron. It contains a mild topical steroid, a topical antibiotic. It's all in a moisturizing base. It's 8/9 moisturizer, you guys. 8/9 moisturizer. When I first read about this, I totally poo-pooed it. And then I started to use it in some tough patients. This stuff is magic. I'll show you pictures. So with this recipe that I listed here, it makes a 1/2 pound tub. Having patients mix the ingredients on their own does not produce the same results. I'll show you pictures that prove that. I know why people do it. They want to get it covered by insurance, and most commonly compounds aren't covered by insurance. But it's worth the money to get it compounded. It just simply works so much better. A 1/2 pound tub at the pharmacy I use in Idaho, which is called Portico, it's $45, and Portico will ship elsewhere. So if you want to prescribe this and your compounding pharmacy says it's going to be $100, have them go to Portico, and Portico will ship it to their home. This is safe enough and dilute enough. You can use it up to 5 times a day for bad flare-ups, and you can safely use it every night at bedtime for prevention and maintenance. It's especially great for little babies and toddlers with those really bad cheekies. You know, their cheeks are just so bad. I'll show you pictures. This is before and 3-week follow-up, you guys, just with Aaron regimen. That's it. Baseline and 3-week follow-up. Baseline and 3-week follow-up. And I told this mom, I said, families tell me stuff gets better within 72 hours, but I see babies at 3 weeks. I wish I could see that improvement over the early period of time. She said, I can help. She had taken time-lapse photography of her baby from the day they got it through the next 3 days. So you can see just how rapidly this stuff improves. This is a baby that was using DIY Aaron regimen 5 times a day from their pediatrician, and the baby still looked like this. I said, trust me, we just have to have it compounded. This is that same baby 3 weeks later. Same onesie, cuter face. So not useful to DIY, you want to have it compounded. We have 3 new topicals that are non-steroidal, you guys. Steroid-free, approved for atopic dermatitis. Tapinarof is approved down to age 2. This is naturally derived. It has a beautiful origin story. It stems from the guts of worms, you guys. The active molecule was discovered in the guts of worms as a means of obtaining homeostasis in the worm, and who knows who said, hey, let's make a topical and put it on some skin. But wonderful backstory that parents really eat up, impressive efficacy, and it's just once a day application. Roflumilast 0.15% cream is approved age 6 and up, also once a day. Patients were advised to use it twice a week for maintenance, and over a year, 57% of them didn't have to go back to daily use. So really cool for maintenance therapy. And then topical ruxolitinib is approved age 12 and up, very soon going to go down to 2. It's a topical JAK inhibitor. It works super fast and super well, and it'll be really nice to have it approved for the younger kids. It's also really great for folks with a tactile sensitivity, which a lot of our eczema kids have, that don't like the feeling of anything on their skin. Topical Rux never burns and stings, and it's really fantastic. Whenever I prescribe topical Rux, I tell families 2 things. It's approved to treat up to 20% BSA. The size of your hand is 1%, and so it's approved to treat up to 20 hands. And then secondly, there is a boxed warning on the entire family of JAK inhibitors that was based on a study on a different JAK inhibitor called tofacitinib in patients with rheumatoid arthritis. And because of safety concerns from that study, the entire family got the warning. And I tell families, when you think about it, topical ruxolitinib is a little bit like Kendall Jenner. She's low drama, but she's in the same family as Kim and Chloe and Courtney and Kylie, higher drama. Everybody gets it. Everybody's like, oh yeah, okay, I understand. I'm so sick of just getting another prescription for another cream. Isn't there something else that we can do? Absolutely. We have dupilumab, and dupilumab turned 8 in March. And this is a biologic that works by inhibiting IL-4 and IL-13. It's approved down to the age of 6 months old, you guys. 6 months old babies can get Dupi. It is a shot. It is an SHOT. It's either every 2 weeks or every 4 weeks based on your age and weight. It's not a steroid. It's not an immunosuppressant. You don't need any blood work with it. And Dupi changed our worlds. In fact, when I think of Dupi, I hear a song in the back of my mind, and anybody, any guesses? Hit me with your best shot? No. That song is My Life Would Suck Without You by Kelly Clarkson. Because before we had Dupi, picking a systemic agent to treat bad atopic dermatitis was like picking a porta potty out of a row of porta potties. You know they're all gonna suck, but you gotta pick one when you have to go. I was never excited to put a patient on methotrexate or cyclosporin. I did it out of desperation because I had no idea how else to help them, and I desperately wanted to help them. And now we don't have to pick a porta potty anymore, which is wonderful. This is my patient Rory. Rory's 4, and this photo was taken a month after she started Dupi, and it's monthly in the little kid, so at this point she had only had 1 SHOT. And her mom tells me at this visit that this is the first month of Rory's life that she hasn't climbed in bed with her and her dad. And so that means Rory's sleeping better, which means the parents are sleeping better, which means everybody is happier because sleep is everything. This is Skylar. When I first told Skylar about Dupi, she's 8 years old. When I first told her about it, she was a hard pass. Very needle phobic, didn't want to do it. And then we're talking about her eczema. And it turns out she cries every night because her skin hurts so bad, itches so bad, she's so uncomfortable, she's so self-conscious. And I said, I don't know about you, Skylar. I'd rather cry once a month when I'm getting a shot than cry every single night. And so during that visit, she turned around and she started Dupi. And this photo was taken a month after we started. And I said, Skylar, what's the best part? And she said, well, people are nicer to me now. Like, I didn't know it. I don't even think her parents really realized it, but she was getting bullied because of her eczema. And now that has gotten so much better for her. Thinking about the impact of atopic dermatitis, there's so many facets to this, and while it's important to think about the side effects of a medicine we're considering, it's also important to think about the side effects of not controlling your child's atopic dermatitis, because those consequences are huge. I wanted to focus on 3. So thinking about allergies and asthma. We now have studies showing that early use of Dupi in kids with atopic dermatitis reduces the risk of allergies and asthma. So we can thwart the atopic triad with early introduction of dupilumab. How early do we need to be? We don't know. Does it need to be the first year of life, the first 2 years of life, the first 5 years of life? We don't yet know, but I'm sure we'll get more clarity on that in the coming years. We have long noticed that kids with bad atopic dermatitis are small on growth curves for height, and we wondered why. And it turns out it boils down to sleep. So when kids with eczema sleep, they don't sleep as well, and they don't enter REM as long or as often. And it's during REM sleep that growth hormone is secreted. So physiologically, these kids are low in their growth hormone. Growth hormone also contributes to bone strength and development, which helps explain the increased osteoporosis, osteopenia, and fractures that we see in kids with atopic dermatitis. So could we improve the atopic dermatitis, help kids sleep, and get them to grow? And the answer is, yes, we can, to quote Barack Obama from years ago. Yes, we can, and I'll show you the data. And it has become quite clear to me that growth is the issue that really speaks to parents. When you mention that their child could be short because of their eczema, you have their full attention. Their ears are wide open, like, oh, well, I didn't know that. Let's definitely treat it. Let's definitely make this better. And I joke that it has become quite clear to me that nobody wants a short child, which I try not to take offense to, as I stand here proudly at 5'1.5". But you talk about growth and you have the parents' full attention. This study looked at Dupie versus placebo in 6 to 11-year-olds, and they looked at the growth over 16 weeks, you guys, just 16 weeks. And over 16 weeks, a third of the patients on Dupie grew at least 5 percentiles in just 16 weeks, compared to 10% of the kids on placebo. So this is a real thing. They also looked at bone growth biomarkers, and they found those increased over 16 weeks of Dupie. So we can get kids to grow. ADHD. We've long observed that kids with bad atopic dermatitis have higher rates of ADHD, anxiety, depression, learning disorders, learning disabilities, autism spectrum disorder. We wondered why. Well, it turns out it could be because of excess IL-4 on the developing brain. So a study that was published in our Peds Derm literature 2.5 years ago pointed to this as a potential cause. Using mouse models, they found delayed cognition and decreased myelination in the atmosphere of excess IL-4. So if we have a medicine that works to inhibit IL-4, could we improve some of these things, specifically ADHD? And the answer is yes. This study looked at the use of ADHD meds before and after patients with eczema were started on Dupie, and they found a marked reduction in the need for ADHD meds on dupilumab. What's to do with vaccines for these kiddos? Because per label, non-live vaccines are fine. Live vaccines are to be avoided. The recommendation that most peds derms are doing is we give the Dupie, we wait a month, they get their live vaccine, we wait a month, then they restart Dupie. And they're just getting their SHOTs once a month, so they're just skipping one Dupie shot. But we also have a remarkable article from our allergy colleagues looking at the immunology of Dupie and the immunology of live vaccines, and they see no reason why we need to worry. We also have a case series of 38 patients down in Brazil who needed yellow fever vaccination, and they were on Dupie at the time without any breaks. There were no complications, and they actually did serologies afterwards, and they mounted an appropriate immune response. So I'm definitely worrying about that less these days. When I first bring up the option of Dupie for patients and their parents, these are the things I say. It turns the eczema into something they're thinking about once or twice a month rather than every single day, multiple times a day. That 5 seconds of ouch once a month is worth feeling better all the other seconds of all the other days. If I'm feeling a teensy-weensy bit passive-aggressive, I say it's getting to the root of the inflammatory process. How many of you guys have heard about the root? Oh my gosh, drives me bonkers. And if I'm feeling integrative, I say it balances the cutaneous ecosystem and restores homeostasis in the skin. It's true. We've got new biologics. We've got 2 IL-13 inhibitors, tralokinumab and lebrikizumab. Lebrikizumab offers a less ouchy SHOT compared to Dupie with the convenience of eventually monthly maintenance dosing instead of every 2 weeks, which is cool. And the nemolizumab is an IL-31 inhibitor. IL-31 is our itch cytokine, and so it's working to target the itch. It's kind of testing the theory that eczema is the itch that rashes. So if you target the itch, you're going to make the eczema better. And so it's nice to have these choices. One of my patients on lebrikizumab, he was doing great. His name's Devin, doing great. And he was so happy at his follow-up appointment that I said, can I tell your story during conferences? And he said, yes. And I was like, can I show a picture of your beautiful face? And he said, yes. I was like, okay, show me how happy you are. And this was him. And I was like, no, like you're really happy. Like you're really excited about what lebrikizumab, like you're really happy. Let's try again. This is what I got. Teenage boys. We also have 2 oral JAK inhibitors to treat atopic dermatitis. Both of them are approved down to the age of 12. And these medicines work extraordinarily fast and extraordinarily well to treat atopic dermatitis. They offer endpoints like EASI 90, a 90% improvement in their EASI score, itch 0-1, meaning little to no itch, and improvements in quality of life. This is data for abrocitinib. This is for upadacitinib. These are powerfully effective agents for atopic dermatitis, and they're pills. This is my patient, Wesley. So Wesley's 10 in this picture, and he had a suboptimal response to Dupy, so we got him on upadacitinib off-label. And so this photo was taken a month after he started upadacitinib. And I said, Wesley, how do you feel? And I'll remind you, he's 10. He said, I haven't felt this good in years. This is another one of my patients that did really well on an oral JAK inhibitor. And I asked him, I said, can I share your story during conferences? He said, yes. I said, can I show a picture of your smiling face? He said, yes. I said, can I tell people your first name? He said, I'd prefer an alias. I said, okay, sure. What do you want to be called? He said, Han Solo. So Han Solo here has what we call eczema psoriasis overlap affecting the palms and soles. And I have found oral JAK inhibitors to be the best thing for patients with this. And so these pictures were taken at the beginning of treatment. This is him before and just 1 month on his oral JAK inhibitor in his hand, and 1 month after starting the oral JAK inhibitor. Really remarkable improvement. There is a box warning on the JAK inhibitors, and whenever I get to the slide about the box warning, I hear Taylor Swift in the back of my mind saying, it's me. Hi, I'm the problem, it's me. Because these medicines offer such a potential for wellness for difficult to treat conditions that we have never seen before, and they would be flying off the shelves like Ozempic if it weren't for the box warning that gave a lot of people a pause. My safety spiel when it comes to the oral JAKs, I say these medicines are wonderful, but they have a little bit of safety baggage that I can sum up in 3 things. Number 1, we do have to do blood work on these medicines. Number 2, they do increase the risk for certain viruses like the cold sore virus and shingles. And number 3, there is a box warning on all of these medicines in the family because of a study done on tofacitinib in patients with RA who were all older than 50 with at least 1 cardiovascular risk factor, and they were all also on methotrexate, and 57% of them were on prednisone. And because of safety concerns from that study, the entire family got the warning. I've reviewed your past medical history, I've reviewed your medication list, and I think the benefits far outweigh the risks. And so that's how I discuss it in clinic. My last section is on inflammatory and autoimmune disease in kids, and we've noticed a huge increase in the amount of autoimmune inflammatory skin disease that we have seen with regards to psoriasis, hidradenitis suppurativa, alopecia areata, and it's not just in derm. Increased rates of IBD, increased rates of inflammatory arthritis. Why are we seeing so much more of this? There are 2 most popular theories. The first is climate change, that as our air quality decreases, the oxidative stress on our skin increases and creates more inflammation. The other theory is that our gut microbiome as a species of human beings has evolved over the years and has created a more pro-inflammatory state. And I think it's both, and I think they're playing off of one another, because it turns out as our air quality decreases, the quality of the food grown on our planet decreases, which has an impact on our gut microbiome. And I wonder if in 5 years from now, I'll be back here in Ogden telling you guys about the use of poop transplants for alopecia areata. The future is poop, you guys. You heard it here first. The future is poop. They are already approved for treatment recalcitrant C. difficile, and there are companies out there that offer the perfect poop. And when I heard about these companies, just ideas for slogans just started like pouring out of me, you know? Like, we're not a piece of crap, you know? Our shit don't stink, you know, that sort of thing. Like, the opportunities are endless for where you could go with that. What do we do in the meantime? We can't fix climate change. We can't restore our microbiome. What do we do in the meantime? Well, we're more equipped than ever before to help manage this. We have 4 biologic agents approved for kids with psoriasis listed here, and more are on the way. We also recently got the approval of an oral agent, oral apremilast, for kids down to the age of 6. This is one of my patients, Evelyn. She's 3. She's covered in psoriasis. It was so bad. We tried everything. Topical steroids, topical non-steroids, light therapy, methotrexate, tried it all. It didn't budge. So I got her on ustekinumab off-label. It's approved down to 6. I got her on it off-label. And this was the day of her first SHOT. This was 1 month later when she came in for her second SHOT, and this was 3 months after that. And she said, Dr. Swanson, my ouchies are all gone. Happy as can be. This is Sam. Sam had horrible nail psoriasis. I forgot to take a before picture of his nails. Shame on me. But this is his after picture where his nails were all beautiful and looking great. And I said, Sam, what can you do now that you couldn't do before? And he said, I can play video games all day. I'm like, great, Sam. That's awesome. This is Joanna. She's 6. She has bad nail psoriasis. I did remember to take a before picture of her nails. And we got her on Ustikinumab. And a year later, these were her perfect nails. She was doing great. I said, Joanna, what can you do now that you couldn't do before? She said, play with Legos. Her dad said, pick her nose. You know, whatever freedoms the treatment allow you, I'm happy for you. A quick comment on vitiligo. We have a topical medicine, topical ruxolitinib that I mentioned in the eczema session that's approved down to 12 years old for the treatment of non-segmental vitiligo. This is the most effective agent we have ever had to repigment vitiligo. And it works the best in sun-exposed areas like the face. It used to be kind of a bummer to see a person with vitiligo on their face. Now I'm excited because topical rux will work and we can bring their pigment back. I always combine it with a supplement called Polypodium leucotomus, and it helps protect your skin from the sun, but counterintuitively, it makes light therapy work better for conditions like psoriasis and vitiligo. So we know topical rux works better with light, and light works better with Polypodium leucotomus, so I build on those betters for the absolute best results. Polypodium leucotomus is over the counter. It comes in a capsule, but you can open it up and sprinkle the powder on food or in juice so kids can take it. It's safe and effective based in a natural fern leaf extract from South and Central America. This woman is the mother of a couple of my patients, and while I'm seeing her kids, I happened to notice her vitiligo, and I said, oh, I see you have vitiligo. She broke down in tears. It had really been a devastating journey for her. I said, we actually have something new that works really, really well. And so we made her a patient, we got her registered, we started her on topical rux and Polypodium leucotomus, and this was her 3 months later. She said, you gave me my face back. You gave me my life back. Improving vitiligo can have a huge impact on patients and their families. This is another kiddo of mine. His name's Lincoln, and he had segmental vitiligo, and he's 8 years old. So I was off-label in 2 ways, but I really wanted to use topical rux, so I gave him samples. And this was him at baseline, 2 months in, 4 months in. You can see remarkable improvement. And I said to him, and as I looked at these pictures, I was like, Lincoln, why so glum, chum? Like, your vitiligo is looking so great, yet you're looking progressively sadder in these pictures. And his dad said, no, he's very happy that his vitiligo is better. He's just not a morning person. And the 2 later pictures were taken during morning appointments. We are also using oral JAK inhibitors to treat alopecia areata, and this is the best thing we've ever seen for alopecia areata, you guys. We can bring people's hair back. The first case report of using an oral JAK for alopecia areata, it was a young man in his 20s that had had alopecia universalis for 15 years. He hadn't had a hair on his body for 15 years. He also had rheumatoid arthritis. And he was put on tofacitinib for his rheumatoid arthritis, and all of his hair regrew. And everybody was like, what? Because to treat alopecia universalis, that's historic. And it started the JAK revolution. And when it comes to alopecia areata, I've got a fever. And the only cure is more JAK inhibition. This is quickly becoming the best and only treatment, especially for people with bad alopecia areata. This is Brooke. Brooke was the first patient that I put on an oral JAK inhibitor to treat alopecia areata. She's 35 in this picture. She had had alopecia areata for 20 years. Never totalis or universalis, but always significant enough that she always wore a wig. At 35, she had never dated in her life because this started at 15. And so her confidence took a major plummet, and she never felt comfortable dating, and she always had to wear a wig, and she was really uncomfortable. I told her about tofacitinib because the case reports had just recently emerged in the past 2 or 3 years prior, and her eyes filled with tears, like finally hope. I remember the first article written about oral JAKs for alopecia areata. It was entitled New Hope for the Hopeless, and that's truly what these drugs were. So we got Brooke on an oral JAK inhibitor. We got her on tofacitinib off-label. This was her 3 months later, and this was her 6 months later. Full head of hair, doing great. And Brooke, the girl who had never dated, got married 2.5 years ago. This is her dad. No judgment if it was her betrothed, but this is her dad. I said, send me a picture from your wedding, and this is the one she sent. So I'm like, okay, that's cool. This is Emma. Emma is 16 years old, and she has horrible, horrible alopecia areata. Being a teenager is hard enough. Throw bad alopecia areata on top of it, and it really, really stinks. And so we got her on an oral JAK, tofacitinib, off-label. This was her 3 months later. She was like a little chia pet. I still see Emma. She is a senior at University of Kansas. This is her at a football game with her dad. She's still on an oral JAK. She's still doing wonderfully. Her life is forever changed. This is JD. So JD is little, he's 10 years old, and he has alopecia universalis. And so for alopecia universalis, there's no hope except an oral JAK. So I got him on baricitinib, 2 milligrams a day. This was him in November. You can see his eyebrows and his eyelashes. This was him in January. Things are sprouting. And this was him in May. Really remarkable. He said, I look bussin'. I'm like, yes, you do, JD. You do look bussin'. And this is little Stephanie. So Stephanie had significant alopecia areata. She's 3 years old. There's nothing approved for 3-year-olds. But this was really, really distressing. You know, all the little girls, they want to be Disney princesses. We need a Disney princess with short hair. Please, if any of you know somebody who works at Disney, we need a Disney princess with short hair. But she wanted long, beautiful locks. And so we got her on baricitinib off-label. And this was her in June. You can see it all coming in. And this was her in October. I walked into the room and she said, Dr. Swanson, I got a haircut. Just the cutest thing, just melts your heart, because the most important thing a girl wears is her confidence, and these medicines have the ability to give kids their confidence back, and people too, like Brooke. I'll end with this. So this is I feel immense pride in you guys for practicing in Utah and dealing with Select Health. I get a smidgen of it up in Idaho, but you guys, you get a whole lot of it. And Select Health, whenever I think of Select Health, I think of Frau Fabissina from Austin Powers, because she was the founder of the militant wing of the Salvation Army, which I think was actually rebranded as Select Health. And so Select Health, in all their infinite wisdom, decided a couple years ago that they were not going to cover dupilumab anymore for any reason. They just weren't going to cover it anymore for any reason, which I think should be illegal to take a medicine like that has like 8 indications and say they're not going to cover it at all. And so that was upsetting enough. But then my patient, Ben, got caught in the crossfire of this. And so Ben is 5, and this picture was taken before he was started on Dupi. And so we got him on Dupi, and his life changed. Like, whole new kid, like doing wonderfully, sleeping good, playing good, like life is better for him and his family. And then a year later, and Select Health had approved it before their policy took effect. They'd approved the Dupi to begin with. So he comes up for his year renewal. And I had been told that patients under 12 for atopic dermatitis, they could be given a pass from Select Health because there's nothing else systemic approved in that space yet. But we sent in his reauthorization and it was denied. And I was like, well, they just don't understand. They're just following their algorithm. They don't understand that this is a continuation of treatment. They don't understand that he's 5 years old. They don't understand that his life has changed. And so I'll schedule a peer-to-peer review and I'll tell them this, and that will fix it. And so I schedule a peer-to-peer, and I talk with this person on the phone, and I share the story of Ben. And he says, no, I'm going to need you to go ahead and stop the dupilumab and start him on methotrexate for 3 months, and then if that's ineffective, then you can refile for an approval. And I was like, smoke was coming out of my ears. I was like, what? And I was like, calm down, Lisa. Do it classy, you know, like, don't explode over the phone. And so I said several things in those following moments that I wanted to share with you guys in case it helps you with some of the battles that you fight every day. I said, to clarify, you are asking me to discontinue an effective FDA-approved therapy for a 5-year-old and switch him to a non-FDA-approved systemic immunosuppressant that comes with serious potential side effects and toxicities. I just want to make sure that's what you're saying to me on this phone call. I feel that this course of action would violate the Hippocratic Oath to do no harm. This conversation is making me uncomfortable because I feel like what you are asking me to do is unethical and not in my patient's best interest. Talking about this is making my stomach hurt. I do not think that systemic immunosuppressants are appropriate for my patient. By requiring me to prescribe these therapies, you are making medical decisions, and by taking over as medical decision maker, you are liable for any adverse events that occur as a result of forcing me to prescribe these therapies. I refuse to take responsibility for medical decisions that are not my own. I will be documenting this conversation in the patient's chart, so I wanted to ask your name. He said Josh. I said, Josh what? Josh Anderson. S-O-N or S-E-N? S-E-N. Okay, well, thanks, Josh, because I want to make sure to establish a legal trail of the interactions impacting this patient's care decisions. And when we hung up the phone, and when I hung up the phone, I again heard Taylor Swift saying, look what you made me do. I'm a nice person. And you pushed me to the end. And so when we hung up the phone, his stance on stopping Dupie and starting methotrexate was still in effect. He didn't budge, even after all that stuff. But within 10 minutes, I got a call from his manager saying, oh, I'm so sorry, a mistake was made, and your patient will be continuing to enjoy dupilumab. And so, yes, victory. Yes. And the most important thing, A, it feels really good to beat Select Health. Like anytime I can, I love that opportunity. But B, the most important thing is that Ben, my patient, got his medicine and has continued to thrive. Thank you so much for having me.
Lisa. We have time for a couple of questions. We have one from online that says, what do you recommend for molluscum?
Oh, molluscum, yes. So, I mean, that could be its own talk in a whole, there's so much stuff. So molluscum never have to be treated. I always make sure families know that. They will eventually resolve on their own, but we have treatment options available if they'd like. I do prescribe a fair bit of imiquimod. There's controversy about this, but imiquimod is very cheap and very easy. I just have them apply it to 2 or 3 molluscum Monday, Wednesday, Friday at bedtime. So very easy routine. We give it 8 weeks to see if it's going to work. And it's less than $20 on the GoodRx app. Insurance frequently doesn't cover it. I do a lot of Beetlejuice, but less and less these days. It's gotten harder to get. Candida antigen injection, because you just have to treat 1 molluscum with it and triggers immune system response. And then there's a new topical coming in June called berdazimer gel. That's a nitric oxide releasing gel applied once a day to the molluscum, so we're very excited to get that.
Super talk, thanks.
Thank you.
One question or one comment on warts.
Yes.
If you just take a 25 gauge needle and you just puncture the wart about 5 to 10 times, just enough to cause bleeding, I think what happens is you get that Verruca vulgaris antigen in the bloodstream, and all the warts disappear, usually over about 2 weeks.
That's awesome. I will try that. Yes. Yeah, I think anything that makes the immune system is capable of defeating warts. Anything that allows you to introduce that to the immune system is going to help. Thank you. There might be one.
Yeah, with the topical wart treatment you were talking about,
Yeah.
do you see people not get any more warts in the future?
Good question. Because it's working to help trigger immune system response, I see far fewer recurrences than with purely destructive treatments like liquid nitrogen.
But still some.
Still some.
Sure.
It's not a permanent cure.
Okay.
Thank you, guys. Thank you.
Well, I thought that was absolute magic. So thank you, Lisa, for sharing your tidbits. And I think she really, at least for me, I love what I do, and I love to be able to take care of these patients. It's pretty great. We start again at 12:30. Please you can get your lunches and get situated. Thank you so much.